My slides, please. Chairperson, you want to say something? My slides are not here. It's the first talk, actually the organizing committee of UPCSI. My today's talk is the anticoagulation strategy in acute coronary syndrome. Of course, you cannot finish it within time, but I will finish within time because I shall restrict myself to ACS in sinus rhythm. I won't go into ACS with AF. That's another separate talk. And acute parenteral anticoagulation, I will only restrict to. I won't go into long-term OACs because that is another very difficult problem with antiplatelet. Now, anticoagulation, why we need in ACS? Because ultimately we need antithrombotic. And antithrombotic means both antiplatelet and anticoagulant. So you have to be very careful about the terminology. While you're talking about dual anticoagulant, dual antiplatelet, we are actually meaning dual antithrombotic or triple antithrombotic. Because thrombus is the main thing which causes the stent thrombosis. And you know, for the first 1 month, thrombosis is the main concern for the operator and for the patient. But after 1 month, bleeding should be given more respect compared to thrombosis. Because of, as we are hearing, the stents are improving, the polymers are improving, the drugs are improving, the techniques are improving, stent thrombosis chance is reducing by themselves. We don't need much of antiplatelet anticoagulation to stop this thrombosis. We need, but we need much less. But the bleeding remains the same because the patient remains the same. We are not improving the patient manufacturing by help of God. The human model remains the same. Then the unfractionated heparin is important because it is validated and we have good reduction of thrombosis. But the narrow therapeutic range, there is thrombocytopenia and you need close monitoring, particularly APTT. And ideally you should do the APTT every 6 hours as long as the patient is on heparin. Now with bivaleuridine, if you see overall bivaleuridine in ACS patient has got a significant reduction of major bleeding, and there was a big paper from UK which was fiercely challenged by other people on stage during the ESC presentation. I felt sorry for that guy who presented it. But with a marked increase in stent thrombosis. But you know, the bivaleuridine was used only during the procedure. When you can extend the bivaleuridine for another 4 to 6 hours, this is gone. There is no increase of ST stent thrombosis. So we change our tactics as well, but sometimes don't publicize it. Low molecular weight heparin is more predictable and is the standard. But you see, enoxaparin versus heparin, 30-day mortality, absolutely no difference with unfractionated heparin to enoxaparin. Excepting the ease of administration and no need for monitoring, there is no advantage of enoxaparin. If you see the synergy trial of non-STEMI in ACS, you will see the curves are superimposed with unfractionated heparin as far as the death MI is concerned. But the bleeding, there is a significant major bleeding with enoxaparin. There are some points are significant, some points are not, but overall there is bleeding with enoxaparin. It is a myth that enoxaparin does not cause bleeding. In the ATOL, it is a STEMI patient, not non-STEMI, but STEMI with primary PCI. Enoxaparin did not reduce the primary outcome, although secondary ischemic outcomes were reduced. Bleeding was similar with unfractionated heparin. You see the p-value is 0.06, not below 0.05. Again, there was no advantage in STEMI. Now, if we have a newer molecule, not newer, but perhaps dug out from the grave, is the fondaparinux. If you see non-STEMI in OASIS 5, and when was it published? Go back 2006. And we are talking today because, unfortunately, like you, even me, were not so much aware of it. Somehow it was not publicized. I tell you why. The non-STEMI OASIS 5 trial actually showed with enoxaparin, if you see the left curve, the composite of death, MI, ischemia during the hospital stay is absolutely same. But you see the lower curve, the bleeding is absolutely different, 50% less bleeding with fondaparinux, without losing any efficacy. That is in non-STEMI. And very interestingly, death was first time shown to be reduced. Enoxaparin, no death benefit over unfractionated heparin. Fondaparinux, death benefit over and above enoxaparin. So that is very interesting. Then came the patients who undergo PCI, OASIS 5, the subgroup. And here we showed that the venous access complications were less with fondaparinux. But that is not relevant anymore because these are all for femoral. Those are still doing femoral may think of fondaparinux. But those who are going for radial, there is no advantage of fondaparinux because these complications are less anyway with enoxaparin as well. Clinical event are the same. But you know why we did not like fondaparinux because there is twice the chance of catheter thrombosis. And as an operator, I won't like to be in a mess in the OT, in the cath lab. If the phone call comes by from the nurse after 1 day, the patient has got something, stent thrombosis, something, I am a bit relaxed. But on OT, if something happens, it's absolutely on me. So that is the cause of fondaparinux not being popular with the operators because we don't want ourselves to be put into direct mess during the procedure. But there is a big but. It was used without heparin. But nowadays, everybody uses, whether enoxaparin or fondaparinux, with heparin, on-table standard dose of heparin. And then there is no difference. No extra catheter thrombosis. So on one hand, vascular access problems are not relevant for enoxaparin, and this catheter thrombosis is not relevant for fondaparinux. So you are back to square one, enoxaparin and fonda are same. Now fonda in acute STEMI in OASIS 6, again you see, compared to unfractionated heparin, there is benefit of ischemic event as well as there is benefit of major bleeding event. It is a gross benefit. Now, STEMI not receiving reperfusion. This slide I can't show anywhere, perhaps outside Asian subcontinent. This is irrelevant, but to us, it is very, very relevant. I can tell you the reperfusion therapy is still about 50 to 60% patients are getting. If you get the all STEMI throughout India, you go to the villages, to small towns, you don't even know the MI happened, the patient admitted to a local nursing home, got treated for 3-4 days, went home. Never saw a proper cardiologist. So these are the patients where really if you use fondaparinux, you get a benefit. Second is even if you give thrombolytic therapy. Now thrombolytic is very dodgy thing. In outside India, thrombolytic means tenecteplase or retiplase. No role of fondaparinux. Every trial used enoxaparin and the whole protocol, outcome was based on tenecteplase enoxaparin combination or retiplase enoxaparin combination. We do not know what will happen if we take them separately. But streptokinase, which is still 70% of thrombolytic agent in India by the team of Chennai group, 70% thrombolytic is still streptokinase in India. And that is not followed by enoxaparin, but that is followed by fondaparinux, and you get a good benefit. So if you see no reperfusion, fondaparinux is good. Thrombolytic, fondaparinux is good. Primary PCI, don't think of fondaparinux. This is absolutely bad. Grace risk score higher, the better the effect. Swedhart's registry showed that 40,000 patients from Sweden, non-STEMI, use of fonda compared with low molecular has associated with a lower risk of bleeding event and death. So both thrombotic and hemorrhagic complication in short-term and long-term follow-up. Our own group, Dr. Dalal, Dr. Mohan's group, who took everything about STEMI 40%, non-STEMI 25, unstable angina 28, and real-world data showed there is hardly any recurrent event nowadays, as it is all our experience, and bleeding complication is really low with fonda, and they concluded fonda was effective and tolerable when used to manage symptomatic ACS patient, regardless of revascularization procedure, and this has been published only this year, if you see the reference down. And the Brazilian data came about 4 years ago. They concluded, similar to recently published data in international literature, fondaparinux proved superior to enoxaparin for the Brazilian population with significant reduction of combined event and bleeding. So what the recent guidelines are saying, for ESC 2020, non-STEMI, unfractionated heparin is recommended undergoing PCI. In case of medical treatment or logistical consent, For transferring the patient to PCI within the time frame, fondaparinux is recommended, and in such cases, a single bolus of unfractionated heparin is recommended at the time of PCI. So those patients who are treated in the peripheral centers, in a nursing home, small hospitals, getting the thrombolytic and will be transferred not within 24 hours, but maybe 3, 4, 5 days when the patient is ready, financially ready, transport is ready, and so on, the doctor is ready. You can better use fondaparinux than heparin or enoxaparin. This is the area. And enoxaparin should be considered pre-treated with subcutaneous enoxaparin. That is 2A, not even 1, that is 2A. And bivaluridine is 2B. And the 2017 STEMI guideline, that was non-STEMI. What is STEMI? Anticoagulation is recommended for all patients with antiplatelet. Routine use of heparin is recommended. In patient with heat, bivaluridine is recommended. And there are 2A. Routine use of enoxaparin is 2A, bivaluridine is 2A, fondaparinux is contraindicated in primary PCI. But when it is fibrinolytic, when you use the streptokinase, if you see, if it is streptokinase, fondaparinux IV bolus followed by 1 subcutaneous dose 24 hours later. Simple regime saves your patient. But if it is tenecteplase or retiplase, never think of fondaparinux. It is always enoxaparin. So I summarize, my friends, STEMI ACS, immediate invasive procedure, anticoagulation, fondaparinux is not a consideration. Give enoxaparin, or even I would better say, go to standard dose of heparin. That is the standard. If it is NSTMI, very high risk, again the same thing apply. If it is high risk, you get some hours, 2 to 24 hours, not rushing around, then anticoagulation and fondaparinux, enoxaparin are equivalent. If it is delayed by 1 to 3 days, like most patients of India, not the most patients, the doctors seeing over here, because we are all working in metro or big cities, so we don't see this class of patient. It should be told to our colleagues that anticoagulation is recommended, preferably fondaparinux. And anticoagulation recommended for 5 to 8 days, again preferably fondaparinux. So there I stop. There may be some comments from the chairperson and panel.
Thank you for a very nice presentation. Any questions from the panelists?
So it was a very nice presentation. There's few queries from my side. Especially regarding the use of bivaluridine, except heparin-induced thrombocytopenia, in which condition or situations you prefer the use of bivaluridine? And the other points I would like to highlight in relation to fondaparinux, as fondaparinux is a suitable agent, especially in if we are doing pharmacoinvasive approach, which we are commonly following in developing countries like India. And in relation to enoxaparin, the single dosing is also very favorable factor in relation to fondaparinux.
Yeah, the first thing is that bivaluridine, my personal experience is very little, but it depends on your personal choice. Like my colleague Dr. Hajra was here, he was using for bivaluridine by default at some point. And as long as I said, you don't stop the bivaluridine after the procedure immediately, but follow it up for 4 to 6 hours, the results are excellent. And you don't have to check any APTT or anything. So these are very good results, particularly with the radial approach, it's really good. And for fondaparinux, as I said, it is really good. It is under publicized, underused, I would say. But huge number of our patients are getting streptokinase in the peripheral center, then getting referred casually, not as a hurried way, 3, 4, 5 days. Many patients come. I had a heart attack 1 month ago. I was admitted to a local hospital. Now please look. Those are the ideal patients, and this is a big chunk of patients who should have fondaparinux. As you said, no monitoring, no safety concern, once daily or 2 doses only. So that is really good. As long as we are aware and we spread the awareness to the mofussil areas, to the semi-rural, rural areas. That is very important. This is not perhaps the very good molecule for a metro city, for a cath lab center. But this is a fantastic molecule for small nursing homes in the periphery, in small towns.
Thank you very much.
Okay. Thank you.
Thank you, Professor Ray. We look forward